Buenas tardes a todos, 5 de la tarde, hora de México, horario en punto. Es un gusto para mí poder presentar este webinar en donde tendremos a 3 participantes, el doctor Marco Alcántara, que será el coordinador del webinar, y tenemos 2 personalidades en el mundo del intervencionismo, iniciando con el doctor Brilakis y el doctor Jay, que estoy seguro tendrán una exposición sumamente de provecho para todos nosotros. Agradezco mucho a todos. Marco, es un gusto poderte presentar. Gracias por estar. Marco.
Digal, muchas gracias por la invitación por parte de SOCIME y SCAI. Tengo el privilegio de presentar un webinar con invitados de lujo, que es el doctor Emmanouil Brilakis. Yo creo que no hay alguien que haga intervención de oclusiones crónicas sin que sepa quién es el doctor Brilakis. Él es el director del programa de intervencionismo complejo en el Instituto del Corazón de Minneapolis. Él es autor de uno de los libros más citados de cardiología en intervenciones crónicas. Y bueno, pues no necesita mayor presentación. Y de igual manera tengo el gusto de presentarles también a otra personalidad en el mundo de las oclusiones crónicas, que es el doctor Khatri. Khatri es el director del programa de cardiología intervencionista en intervencionismo complejo en la Cleveland Clinic. Y bueno, pues tenemos 2 invitados de lujo y me siento galardonado por poder presentar a estas 2 personalidades. Dr. Brilakis, thank you very much for accepting the invitation, and I will appreciate if you can start with your lecture. Thank you very much.
Wonderful. Thank you. Thank you very much, Dr. Alcántara, and it's a great pleasure and honor to be here today with everyone to do a brief overview of the Cto Pci literature. As we were discussing before with Dr. Alcántara, there's been a lot of action on CTO in Latin America, and I want to congratulate you actually for getting the movement going and increasing the complex PCI in this part of the world. So here is, these are my disclosures, and this is a slide showing that there's been an increase in the number of publications in CTO interventions over the last few years. If you look at 2019, 2020, we have 284, and obviously I cannot speak for all of them, but I will present some of the key ones over the last year. I broke them down to 4 parts, and the first part is about the indications of the procedure. And one of the main developments have been the long-term outcomes from the EuroCTO trial that were presented by Gerald Werner at TCT last year. As you may remember, the EuroCTO trial randomized 400 patients to either Cto Pci versus medical therapy alone. And it did show better quality of life improvement if you had the intervention versus medical therapy. And this was the long-term endpoint, so that the safety was about the same. So there was no difference into the survival over time. The incidence of death and myocardial infarction were similar in the 2 groups. So very good outcomes, showing a very good safety profile for CTO intervention with superior symptom improvement. This is another small study for a rare indication for Cto Pci, which is to prevent ventricular arrhythmias. These are patients who had recurrent ventricular tachycardia, and after Cto Pci, there was a significant reduction in the area of scar that could translate to less incidence of acute events. Moving on to general outcomes, there's been 2 publications during the last year from the LATAM CTO registry, and this is the first one of them. And again, I want to congratulate the whole group. I know it is many people who worked very hard to make this a reality, but it did show very good outcomes and joins the other parts of the world in terms of procedural success and the risk of complications. 81% success, 3% risk of complications. Dual injection was 53%, a microcatheter was used in 69%, and the fluoroscopy time and the other measures were very similar. The retrograde and dissection entry rates were a little low, but that's to be expected in expanding and rapidly expanding programs. Moving on to the global trends, this is from Progress CTO, showing that actually in the recent years, there has been a trend towards less complications without sacrificing success rates, which are still between 80 and 90%. This is one of the most recent papers that comes from James Pratt and Simon Walsh, showing that patients who have dissection reentry versus non-dissection reentry technique, they both had very good outcomes. The ones with dissection reentry are more complex lesions, as you might expect. However, the outcomes were very good in both groups, with similar incidents of pre-procedural myocardial infarction and events down the line. And the quality of life improved significantly between before the procedure and in 12 months. Diabetic patients did have significantly worse outcomes compared with non-diabetic patients.
Dr. Brilakis, to interrupt you, but the slides are not moving. If you can refresh, or sorry for the interruption.
Oh, no, absolutely. Can you see them now?
Manos, they're fine on my side.
No, Manos, they are not moving.
Yeah, I wonder if it's a Zoom situation. I'm just moving on to the next one. I don't know if you can see it now, the previous bypass surgery.
Okay, it's working fine for me.
Okay, so and we're discussing one of the complexities is the number of previous bypass patients. This is a meta-analysis showing that people who had bypass had more complex lesions, as you may expect. And as a result, there was less success, about 6% less success with bypass patients. So this is the one group of patients that still remains fairly complex in the ones who undergo CTO PCI. And this is a newer score. As you know, there are multiple scores to predict the success and the difficulty of the procedure. This one is the Euro CTO Castle score that has the similar parameters than the JCTO, the standard for this, along with previous bypass and age more than 70 years. How about treating non-CTOs at the same time? This can be done, although the downside is you use much more radiation and you use more contrast and it takes longer time. So this is something to be taken into account when treating those complex lesions. How about the learning curve? It looks like the more procedures you do, the better success you get in terms of stents, crossing the lesion, procedural success. So it is like everything else, the more of these procedures you do, the better you get, the better your lab gets, and the better outcomes you can achieve. And here are some insights regarding the techniques. There was a paper published late in 2019 showing a global consensus in terms of how to do CTO PCI. I think everyone agrees at this point that the key indication is to improve symptoms. And it is important to do dual angiogram and look carefully at the angiogram to plan the procedure. And this is why I think increasing the percentage of dual angiography for CTO PCI, that's something critical for improving both the success and the safety of the procedure. Using a microcatheter is very useful. I know sometimes cost can be prohibitive, but if it's possible, it helps the procedure be more successful. All crossing strategies are important. It is important to change to improve the success. And then ideally, those procedures should be done by centers and operators who are experienced at doing this. And then once you cross, don't stop it there, but take the time to optimize the deployment of the stents. Now, coming to the classification of the microcatheters, there are multiple new devices available. Again, every country has their own particularities, but there are multiple options with different characteristics. Coming to access, radial access has increased significantly for CTO PCI. This is for Progress CTO. Nearly half the cases actually have at least one radial access. And if you look at change over time, it went from 11% in 2012 to 67% in 2018. So a rapid increase. 2/3 of CTO PCIs currently have at least one radial access being used, including distal radial access. This is actually starting slowly to gear up as well. There was a new algorithm for wiring the CTOs, emphasizing the time limits, giving 20 minutes to guide wire manipulation time, which for many operators might be a little too generous. Usually you try for a few minutes with a few wires. If it doesn't work, you change something. But this is a good practical algorithm that reinforces some of the previously presented algorithms. There's another paper about using a new IVUS catheter with low profile and having three-dimensional reconstruction to be able to direct the guide wire towards the true lumen. There is a very cool technique about increasing the support. It's called the deep wire technique. It comes from Russia, Oleg Resyanov and Dmitry Skilitsky. And this is actually a technique in which you advance a polymer jacket with wire, and then that goes into the cavity and provides very strong support. Now, of course, there's a small risk of perforation, so this should be done spinning very rapidly without any force. But if that goes, it provides very strong support for delivering equipment. How about stent digitization? Again, that's very important. Using intravascular ultrasound improves outcomes, less stenosis, less major adverse cardiac events. If things don't work out, the subintimal plaque calcification or SPAM is emerging as a new technique, which is that instead of the lesion as it is, you balloon the subintimal space, you do not place a stent, you place a patient back in a few months, and as it does is it sets each time the lesion to canalize. When you come back, quite often the lumen can wire easily and place balloons and stents.
Manos, sorry for interrupting, but a lot of people is telling us that you have a lot of like noise in your audio. Can we check that?
Absolutely. Maybe put a different microphone. Okay, can you hear me a little better now?
No, I believe we have some noise.
Okay, how about now?
Much better, much better.
Okay, perfect. So moving on about the different techniques, and this is regarding undergrad wire escalation. There is this classic algorithm that starting with a polymer jacket, tapered wire, and then moving to a stiffer guide wire. And actually, this year, Dr. Khatri just published this paper showing the success who's using XT, XTA, XTR wires, and I think he's going to talk more about this in the next few minutes. So I will leave that for him to explain. Retrograde does remain an important technique for the success of the procedure. And we do have a significant in success when you use the retrograde approach from close to 80 up to 87%, almost 8% increase. So using retrograde, yes, it is more complex. It does have more complications potentially, but also it's critical to improving the success of the procedure. There was a nice review on circuit interventions, the steps of the techniques, the 10 steps, starting from the collateral, reaching the collateral, crossing, and going the other way. And this is another technique that has been very useful, called the Electro Cautery facilitating crossing. This is from Carl Alasved. And this is obviously for select cases in which there is much resistance in crossing a heavily calcified segment. What one can do is to actually electrify the guide wire. So this is connected with a pulse generator. You give 50 to 70 joules in the cutting mode in 2 to 3 seconds. And this is how this looks. This is a retrograde case. It was very calcified ostium and couldn't penetrate, but by electrifying the guide wire, for just 2-3 seconds, it was possible to advance the retrograde Confianza Pro wire through the ostium into the aorta. So doing the electrification truly makes it a highly penetrating wire, which of course requires attention to use it in cases where everyone is very comfortable that things are safe. And I'm going to finish a little bit with a few words about complications. Complications do happen, and CTO interventions do have more complications than non-CTO interventions. And those complications are not only bad for the patients, but also carry a cost. There is actually higher mortality if you have a complication, and the cost is about $900 more per patient if the complications occur. The most common complication is perforation. And this was a nice analysis from Lorenzo Azzalini showing that most of the perforations happen from the wires or the microcatheters. And tamponade happen in 20%, highlighting the fact that if a perforation happens and you put a balloon in quickly, you may actually not allow for the blood to bleed into the pericardium, and then you may actually prevent development of tamponade. Now, the retrograde, we discussed that it's a more risky procedure. However, this is an analysis from another registry called the Open CTO, showing that even though the retrograde cases did have more complications, in reality, some of the complications that happened in the retrograde cases were actually undergrade perforations. So retrograde cases are usually more complex and the risk goes up, and one should be very careful with perforations both in the undergrade as well as the retrograde direction. So to summarize, CTO interventions do continue to evolve, and they do have good results at experienced centers, but still there's room for even more improvement, especially at centers less experienced in doing that. The number one indication is for improving symptoms. And then there are now a consensus about how to do this procedure with microcatheters and dual injection, and perforations do remain the most feared complication of CTO intervention. So thank you very much, and we'll open it up for any questions that may have arisen.
Thank you very much, Manos, for this very impressive presentation. I would like to first ask you, in a dedicated program, dedicated CTO program, now the success rate should be reaching like 85% to 90% perhaps. What are, or where do you think we are going with? Which will be the success rate that you think that we will be reaching in a systematic nature, if we keep on doing these systematic programs and algorithms?
This is a great point. It is a tough one to predict, but the challenge is when you go for the 100%, that's where the complications really take up as well. So we've seen in some experience programs where they became really aggressive and they try to go making every case work, there's some very bad complications happening as well. So in my mind, this is a comfortable success rate. It's a good balance between safety and efficacy. Can we reach 100%? Maybe, but I think we're not there yet. And I think if we try to go for the 100% in the current era with the current equipment, current techniques, my fear is above 90%, you start increasing your complications rapidly. It makes you wonder if it's worth doing that versus accepting some failures, but having less complications at a safer procedure. And I'm curious also on, Dr. Khatri, Jay Khatri's opinion on this, but my feeling is that 85 to 90 is a plenty good success rate. 1 out of 10 is failed, still pretty good, and the complications rate staying 3%, I will take that versus going higher and having more complications.
Jay, what do you think about this? I would really like to hear your opinion too.
Yeah, Manos, I totally agree with your idea on balancing the risk of complications versus success. There's a point of diminishing returns as you try to get above that 90%. But the story is a little bit more complicated than that. I'll share a slide in my presentation about the data that just came out from Michigan showing how little we've actually moved this needle in terms of proficiency in the procedure as a whole in unselected centers. Despite all of these courses, despite all the technology, despite all the techniques, we still haven't really moved much of the uptake of this procedure in unselected centers. So I just want to point that out. It'll be in my slides coming up as well.
Perfect. Very, very, very nice. And the final question, so we can give Jay opportunity to give his lecture, is, Manos, what do you think about, is CTO intervention for everyone? Who should be involved, and where would you put a proctor or someone that helps you doing this type of interventions?
Thanks, Michael. That's a great question. I must say, my feeling is that this is not for everyone, because like everything else, there is a learning curve. And that takes time, and you have to keep some commitment and training and patience, and the results don't come. I mean, to get to the 85, 90%, it happens over several months or years of practice and getting good at it. So my personal opinion is that this is for people who are dedicated to doing complex interventions, CTOs, bifurcations, left main support. I think this is becoming a subspecialty, so to speak, of interventional cardiology. And by focusing on this, then the best outcomes are achieved for the patients, and the operators feel more comfortable with this. I think the worst thing is to have operators not committed to this. They take on very complex cases, they get complications, and then the program shuts down. So no one is best served in this scenario.
Perfect. Thank you very much. now, so we have a very limited time and the topic is very, very interesting. I would like to welcome Jay Khatri. Jay is the director of the Complex Coronary Intervention Program at Cleveland Clinic. He's a very proficient CTO operator, and it's a privilege that he's with us sharing this lecture with all of us. Jay, thank you very much for accepting this invitation.
Thank you so much for the kind invitation from the organizers and also from the attendees giving us their attention tonight. You guys can all see my slides and hear me okay?
Yes, perfect. Thank you very much.
Awesome. So I'm going to talk a little bit about antegrade wire escalation, and I'm going to explain to you through the talk why I think this is so important, particularly in my position as a fellowship attending, where I'm teaching new novice operators how to do these procedures. I think that this can be germane to all operators. These are my disclosures. So why do we care about antegrade wire escalation? Everybody should know how to do this, right? The biggest thing to understand that this is the most broadly applied crossing strategy in CTO PCI even today, and that's across all centers, selected and unselected centers. But there's a tremendous amount of variance in regional emphasis, and I think a lot of this is based on philosophic views on the advantages of one approach versus another, but also on the availability of equipment. The North American hybrid algorithm dichotomizes CTO intervention based on length. So length greater than 20 millimeters calls for different strategies than shorter CTOs, whereas the Asia Pacific and Euro CTO clubs tend to emphasize much more soft tissue tracking and spending more time on the antegrade approach. And obviously there's advantages and disadvantages to both, but the question that I've always had when I go to meetings is why does one group advocate one way and the other group advocate another way? And in particular, recently, both the Asia Pacific and the Euro CTO Club have suggested using not just a soft polymer jacketed wire to start with, but specifically start with Fielder XTR or Fielder XTA. And I found that very surprising that they picked a specific wire. And it's based on the fact that it is very torque responsive and also has unique construction to maintain its tip shape. This wire was available in the rest of the world in about 2014, and it wasn't available in the United States until early of 2017. And so we embarked on a project once the wire became available to see what kind of an impact it could have on antegrade wire escalation in our center. So Manos already showed this slide, but I wanted to point out a couple of things. Using Fielder XTA or XTR as an antegrade first strategy on every single CTO for 18 months, this is the kind of results that we found. So obviously in easy lesions, we have a very high success rate just with one of these wires. And the success rate becomes even higher when you add a stiffer wire to the mix. And obviously as the lesions become more difficult, the success rate drops, but compared to historic controls, 60% for a JCTO 2 to 3 with just an XTA or R is actually very, very good and quite a bit higher than what you would expect. And what was really interesting is even when the hybrid algorithm suggested to go retrograde or to do dissection reentry, we got 44 and 24% success just using antegrade wire escalation with these two wires. And what I think is the most interesting thing is that if the wire crosses very quickly, and that's independent of the JCTO score, and it's also independent of what the hybrid algorithm suggests. So there isn't a lot to lose in terms of procedural efficiency by trying with one of these two wires. If it's going to cross, it tends to cross very, very quickly with a very low likelihood of a complication. And this may potentially broaden the scope of lesions that could be approached, particularly by novice operators, people who are not quite as far advanced in their experience with the more advanced crossing strategies. Why is this important? And I talked about this in our discussion earlier. So Manos published this paper back in 2015 looking at the NCDR database, where the overall take rate for CTO intervention represented less than 5% of over PCI volume in the United States. And the success was only around 59%. If you look at Michigan's database, which was published just last month, now this is after 10 years of advancement in technique, 10 years of advancement in teaching, 10 years of advancement in algorithms, you see that the overall attempt rate is still less than 5% in Michigan in unselect centers, and the overall success rate remains flat at less than 60%, and if anything, the complication rates have increased. So despite all of these advances, we still have a lot that we need to do. And I think that focusing on the basics like antegrade wire escalation is one of the keys to try to move this bar a little bit. So let's get into the approaches that you need. So the first thing is microcatheter. I think you have to have a microcatheter for a successful antegrade wire escalation approach. It allows you to reshape the wire. It improves the torque response. It improves the penetration efficiency of the guide wire. And without it, I think your success rates are not going to be as good as they could be. Microcatheters come in different flavors. I'm not going to get into all of this. Basically, you can get 135 or 150 length microcatheters. They can come in torqueable or non-torqueable varieties. And there are low and high profile varieties as well. High profile catheters give you more push. Low profile catheters give you more ability to get through tortuosity. I think a shorter shaft is better for antegrade wire escalation because it can transmit the force a little bit more efficiently. But a lot of this is going to be based on local availability. Microcatheters are not always perfect. If you over torque a microcatheter, you can fuse it to the wire, and then even though you cross the CTO, everything has to come out as a unit and you'd start over again. On the panel to the right, you can see a microcatheter that was over torqued, and you can see the tip just breaks right off. If you look here, you'll see the tip will just break right off from over torquing. So things to be aware of and careful about when you use these devices. Let's get into the heart of the matter, and that's the wires. And this is the algorithm that we use at our hospital. Wires for antegrade wire escalation come in 3 categories: low tip load, intermediate tip load, and high tip load. And the low tip load wires that we use are Fielder XTA or XTR. The idea here is to try to cross intimately, to let the wire passively slide through and find soft tissue or microchannels. And I'll explain to you what I mean by passive sliding in the examples coming up. The next category is intermediate wires. And in this case, we're talking specifically about the Gaia series. And in this idea, we're trying to cross actively. We're actually trying to control the wire using deflection and rotation of the wire. And I'll show you examples of that to try to cross either intimately or subintimately through fibrocalcific plaque. That's much harder than a soft wire can cross. And then I'll give you some examples of some other intermediate wires that are not part of the Gaia series as well. And then the last category is the high penetration wire, the Confinza Pro 12 and the Estado. And I'll show you examples of when I use these 3 categories. CTO antegrade wire escalation requires a very small tip, and this can only be delivered to the proximal cap using a microcatheter. It's very difficult to deliver a 1 millimeter tip through a tortuous vessel to the cap. So just another reason to try to use a microcatheter if at all possible. A large bend on a wire makes it very, very difficult to cross through a microchannel. These are some of the technologies that these new wires have that allow them to have the torque response and tip retention that we're talking about. The so-called dual coil composite core construction that Asahi has pioneered. These wires are not perfect. If you over torque one of these wires, you can actually break it. So this is the inner coil broken. That's the outer coil right here. This is unfortunately not visible under X-ray. So if the wire tip stops moving, it's very important to try to sleeve the entire wire on a microcatheter and remove as a unit, because you cannot see this section at all on the X-ray. There are other wires that are not available in the US that are supposed to address this problem, but I'll skip this. Let's get into the cases. This is, I think, what most people would be interested in hearing about. So this is an RCA CTO with a relatively long length, greater than 20 millimeters, I would say. The distal cap is at a bifurcation, making antegrade dissection or reentry less ideal because of the risk of losing a side branch. And there's some moderate tortuosity in calcium. So this is a case that, prior to XTA and R, I think that we would be leaning towards going retrograde. But I'll show you what happened here. So this is a Fielder XTA, and you can see on the left panel, the tip of the wire is deflecting, and this is all that you can do with this wire. You cannot feel anything with a soft polymer jacketed wire like XTA. It's purely by what you see on the X-ray machine, and this deflection is bad. All we did was pull the microcatheter back, and now you can see the wire on the right panel is not deflecting. It's perfectly straight. No feel, purely by visual feedback on the X-ray machine. The lack of deflection means that you are now tracking soft tissue and you're sliding through a microchannel. And that's what you want to see with this wire. And so this is the completion angiogram. So the entire case was crossed antegrade with one wire and the usual techniques to optimize our post-stent result. This is another case, very ambiguous proximal cap, a blunt stump with a large side branch. The lesion's around 20 millimeters. I think that there's a pretty good distal landing zone. But this is a case that can be done antegrade, and I'll show you what we did here. So we like to use a lot of image guidance to do these cases. So the first thing we do is wire up an RV marginal and place an IVUS catheter. And with the IVUS in the RV marginal, you can very, very easily see the cap of the CTO. Now these are very, very tough usually to penetrate with a soft wire. So this is where a penetration wire comes into play. So we use a Confianza Pro 12, which is 12-gram wire, just to puncture. That's all it's used for, just to puncture. And we use the IVUS to confirm that we punctured in a coaxial fashion right here. So this is what it would look like on the X-ray. And then this wire is done. We don't use this wire anymore. All you do is nose in your microcatheter. And again, we swapped out to a very soft wire. So this is Fielder XTR. And all you're looking for on the fluoroscopy is lack of deflection at the tip. If the tip is not deflecting, that means that you are in soft tissue and you are tracking soft tissue, and you can continue on without any risk of being subintimal. The minute the tip is deflecting, that's when the wire is subintimal. There's nothing to feel with this wire. And so this is the completion angiogram. So punctured with Confianza Pro 12 with IVUS, and then crossed with a very soft polymer jacketed wire. With a nice result, all the side branches are preserved. This is a young man who ideally should have had bypass surgery, but for whatever reason decided that that was not for him, so he was referred to us for multivessel PCI. He has a blunt proximal cap at this LAD right here. The CTO length is very short, but there's a bifurcation at the distal cap. So we want to be very careful about getting through here. We'd already fixed his RCA and hoped that he would have some septal collaterals, but he didn't. So this had to be done antegrade. And what we did is we put the IVUS in again to make sure that we were probing correctly. And we probed with a Fielder XTA and noticed that the tip was starting to deflect. So the minute the tip on this wire deflects, that's an indication that the wire is subintimal. And there's no longer any reason to pursue further with this wire. And you can see underneath the wire, that's the true lumen right there underneath. Once a soft polymer jacketed wire is subintimal, you cannot correct this with another polymer jacketed wire. You have to switch to an intermediate wire that can hopefully track where this wire deflected. So presumably this wire went off course right here. And so right here is where you need to probe with an intermediate wire. So what we did next is we took a Gaia second, and based on where we thought we were deflecting, we probed with that area. And what this wire does is as soon as you see it deflect, you rotate the wire. So as soon as you see a deflection with this wire, it's the opposite of what we did with the soft polymer wire. We want to see this deflection. We can feel this deflection, and you can confirm that it's deflecting on the X-ray. And then as soon as you see it, you rotate. And what it does is it literally tears through that fibrocalcific plaque. And so this is a different technique altogether that you employ once your polymer jacketed wire is subintimal. So it gives you fluoroscopic inputs as well as tactile inputs to determine that you're correct. And so this wire, after it popped through the proximal cap, it was very, very obvious that it was free in the true lumen distally. And so this is the completion angiogram of this case. This is a far more complex case, very, very ambiguous proximal cap with multiple side branches, absolutely no obvious stump. The course of the artery beyond is very unclear, and then there's a bifurcation at the distal cap. So this is a case that, you know, I think would be pretty tough to do with antegrade wire escalation in the past, but I'll show you how we did this case. Again, put the IVUS in one of these RV marginals, and then we can identify where the cap is, and we puncture it again with a Confianza Pro 12. So you can see that on the IVUS. And since we didn't really know the course of the artery, the idea here was to quickly get subintimal. So a wire that we use a lot for this scenario is a Gladius Mongo. So this is a polymer jacketed wire that's 3-gram tip load, and it's designed to prolapse about 5 millimeters proximal to the tip of the wire. It's intended to very quickly form a loop and get subintimal. So the idea here is we've punctured correctly with the IVUS confirmation, And then we use the gladius mongo to find the true path of the artery without risk of perforation. Now, what's interesting about this wire is it very quickly prolapses, and oftentimes what happens with this wire is it will star right back in, which you'll see at the tail end of this run, that the wire, rather than staying subintimal, it found a side branch and it starred right back in. So you'll see right here at the tail end, right here, it's going to star right back in. And that's lucky. The idea here was honestly just to get subintimal and put a stingray balloon in to do re-entry. But we lucked out, and using IVUS, we were true the whole way and just went ahead and stented. So that's just sort of a lucky result of the gladius mongo. This is another case which we had a very tough cap, and we tried with several wires, including a Gaia third, but we kept deflecting right here. We could not overcome this deflection. So again, in this case, what we want to do is just very quickly get subintimal, because we cannot safely traverse this occlusion with a stiff wire, because we don't really know the course, and we keep deflecting right here. So again, we took a gladius mongo and pointed it at the area that we were deflecting and allowed the wire to prolapse, and basically got lucky again. So you can see on the right panel, the wire prolapses and it starred right back into the true lumen. The idea here is to try to do an ADR at the base of the heart, put a stingray balloon in at the base right down here, but the wire, you know, interestingly was able to star right back in, which is more good luck than anything else, but that's an interesting repeat good luck with this wire. I tend to have a lot of really good luck with this wire. And the last thing I want to share with you folks is, after antegrade wire escalation, there's often important side branches that need to be preserved. So like this case, there's this PLV branch that we'd like to preserve, but you can see this retroflexed origin. This is very, very difficult to try to wire antegrade. So typically in these situations, what we do is we place a hairpin wire in the PDA on a dual lumen microcatheter. So that's what we've done in this left lower panel. There's a hairpin wire, and you pull the hairpin wire back and it will select out the branch that we need to get. The challenge that we had with this is that oftentimes the wire that we use to do the hairpin is too soft to deliver the microcatheter. And what I found is been a very, very good wire for this is a gladius. So rather than the gladius mongo, this is a 3-gram polymer jacketed wire that does not have that special 5mm weakness in the core to let it taper, to let it prolapse. So this wire has like this unique property of being just right in terms of support. So even though we've hairpinned this wire and put a bend in it, we're able to still deliver a microcatheter without it prolapsing. So what used to happen is we would advance a microcatheter. We would advance a microcatheter down to the crux of the heart, and what would happen is the bend in the wire would make the microcatheter prolapse down the PDA. But with this gladius, we no longer have that problem. Even though we've bent this wire, it's supportive enough that we can deliver the microcatheter with ease and save that branch. So that seems to be a nice little trick to use that wire for. This is a wire that was actually, at least in the United States, marketed for peripheral intervention, but I find it very, very helpful for this specific role in the coronaries. So in conclusion, I would suggest that purpose-built soft guide wires in conjunction with a microcatheter can achieve very high antegrade wire escalation success in low complexity lesions with a very, very low risk of complication. And this may be the ideal strategy for folks who are just getting started, who don't have a lot of experience, but also for experienced operators. If this fails for an experienced operator, it's a way to prepare the plaque for antegrade dissection and reentry with a stingray or a retrograde approach. All of those require an antegrade subintimal wire, so why not at least start antegrade to see what happens? And then we can improve the success rates of antegrade wire escalation using intravascular imaging. In this case, I think IVUS is best, and the judicious application of stiff guide wires for puncturing and prolapsing guide wires like the gladius mongo. And I think you can maintain procedural efficiency using an antegrade first approach, irrespective of lesion complexity. That concludes my talk. I'm happy to take any questions that anybody has from the audience or the panel.
Thank you very much, Jay, for this very, very nice and clear presentation. Some guys from the panel and some assistants are asking very, very interesting questions. I would like to start. First of all, everyone is commenting that there is a lot of dedicated CTO material lots of guide wires, lots of, well, a lot of gear. But which is the basic gear that you should have in your shelves in the cath lab so you can deal with this type of AWE cases?
So I think you need to have a microcatheter, period. Okay. And, you know, depending on resources and availability, I would probably select a low profile microcatheter that has torqueability. A fine cross is a reasonable choice, which is, at least in our lab, the most inexpensive, but you should have a microcatheter available for antegrade wire escalation. And then there's 3 groups of wires. You need a low tip load wire. I think Fielder XTA is perfect. You need an intermediate wire, a Gaia second or a Gaia third, and you need a penetration wire, a Confianza Pro 12 or an Estado. So you need those 3 wires, and you can approach almost all of these, at least with the algorithm that we teach our fellows in Cleveland.
Okay, and a very, very focal question is that here in Latin America, there are a lot of countries that have no access to Gaia technology. But we don't know the reason that Asahi has not introduced to our country the Gaia technology. But what if we don't have Gaia guide wires? Which guide wire could you think that could substitute the Gaia technology?
Well, you need something that has a reasonable tip load. You know, these wires have to have an exposed coil. So the first wire to use is a tapered polymer jacketed wire. If that wire succeeds, then you're done. If that wire is subintimal, you cannot follow that with another polymer jacketed wire. It's simply going to follow the same track. Manos, I don't know if you have any other recommendations, but I typically would call for a coil tip wire at that point. So like a Miracle Bro would be a reasonable choice, an Ultimate Bro, if those are available in your markets. But you don't want to follow a failed polymer jacketed wire with a second polymer jacketed wire. It's just going to go where the first wire went.
You know, I agree. I think, as you said, Jay, there is the Miracle is the older version of the wires that are in this tip length. There's also the Judo wires, which are Boston Scientific wires. The Judo are similar in some ways to the Gaia wires, so it's another option that you have. I think the Ultimate Bros, if you have that, that's also a great choice. So you don't have to have, as you said, having one of those, whichever one is more familiar or more cost-effective for every lab. That's great.
I would caution though about the Judo. So the Judo wire, although they come in very high tip loads, they come up to 6 grams. They are very, very long tapers on these wires, and they're really intended for this category 1. They're meant for passive sliding through microchannels. They're not really intended for drilling through fibrocalcific plaque. Even though they have that high tip load, they're not exactly the same role. So Miracle Bro and Ultimate Bro is what I would favor if Gaia is not available.
Perfect. And another question, and we would like the comments from both of you, is that we talk about AWE as a general strategy, but we all know that handling and steering a CTO guide wire is quite complex, and sometimes you can't teach that to a CTO operator. We would like to know, how could you help beginning CTO operators to achieve more control with these guide wires that have complex like handling techniques?
Sure. So that's a very, very important topic. And I specifically showed you angios of fellows in their first 3 months of complex PCI fellowship. So these are all very novice operators doing all the cases that I showed you. And it's based on understanding what the fluoroscopy is showing you and what you're feeling in your hand. So the soft polymer jacketed wire, you're not going to feel anything in your hand. All you're going to do is see that the tip is straight or is the tip deflecting, and that's it. If the tip is not deflecting, you can continue. If the tip is deflecting with a soft polymer wire, you're subintimal and you need to change course. The intermediate wire, you can feel it engaging the plaque, and you can watch on the fluoroscopy as the wire deflects and then rotate the wire to try to actively manipulate around where the polymer wire went wrong. Those are 2 important things that most of our fellows can pick up very, very quickly, that the polymer jacket wire has no tactile feedback. It's purely by lack of deflection or deflection on the screen. And the intermediate wire, you can actually feel what's happening.
Manos, I don't know if you can comment on this.
Sure. No, absolutely. I agree with Jay that actually this is the hardest thing to teach. How do you handle wires, you know, because even when you have an experienced operator next to you, if that operator takes over and does it for you, that doesn't do you any good. And that's actually one of the biggest differences, I would say, between the Western kind of tradition and the Eastern. So in Japan, it's a lot of emphasis on the wire manipulation, having both hands touch the wire, getting the feel of the wire. Now, as Jay said, the polymer wires, you don't have any feel. So this is a great wire to start because it's a pure visual assessment that everyone can have. So this is one thing. Now, when it comes to the Gaias and the more torqueable wires, there are some models. There is the ethos model. Some companies have some models you can use out of the body, which is not the same, but it's better than nothing. So get a little basic feeling of how the wire behaves. One of the common themes people say is when you handle a Gaia, you want to turn and wait for a second or two to let the turn come all the way to the tip, because it takes some time. Now, not everyone does that, but that's one small tip. But end of the day, to learn this, I think this is going to be a matter of experience. No matter what anyone tells you, you will have to do a lot of cases, and eventually you will get what the field is about. And to some extent, there's some luck involved, right? You push a wire, the first time you do CTO, it goes through, you're very excited. But the next time it does not. And that's where the real operator comes through, because if everything goes smoothly in the beginning, there's no problem. So in my mind, you start with the simpler cases, the ones with JCTO score 0, 1, 2, and then you go to the more complex case once you've mastered the basic aspects of handling the wire.
Perfect. And another good question is, when you are dealing with AWE and you get stuck, what do you prefer, to go with a parallel wire technique or simply redirecting the guide wire? Which are the advantages and disadvantages of doing both strategies?
I think that parallel wire is by far superior, because once your first wire is subintimal, it's best to leave that wire there, because that marks where you don't want the next wire to go. And it also can straighten out tortuosity. It can change the conformation of the lesion in a favorable way for the second wire. I'm a big advocate of leaving the first wire there and then going back with the second wire with the first wire in place. It can save contrast. It can dramatically improve the likelihood of success with the second wire.
And I think this is one of those fields that there's a lot of variation between different parts of the world. So in the original hybrid algorithm, the parallel wire was on there and people were not very fond of it. But I agree with Jay. This is, first of all, it's cheap. You don't have to carry special equipment. It works, not all the time, but sometimes it works. It's easy, and you have a decent chance of being successful with the second guide wire through. So I think the parallel wire is great. Now, having said that, when it doesn't work, you have to decide, will you go retrograde or undergrade section re-entry? Has to do with cost, has to do with experience. But I think as a first, especially for beginning operators, parallel wire remains a very important technique.
Perfect. And another question that's being quite repetitive is from the audience is when to stop and when to do investment techniques and how to invest. I would like to hear the comments from both of you.
Well, I think that really has to do with your level of expertise. So, you know, what I tell my fellows when they leave the program is that, look, all of you guys are going to be, or ladies are going to be very proficient in antegrade wire escalation, and you should have no problem tackling an antegrade wire escalation case, and you can get subintimal and stop, and there's no harm done. And it could be that that's all you do, and there's nothing wrong with it. I don't think there's anything wrong with that, at least based on the data that I shared with you in my presentation. These wires are very, very safe, and if they're going to cross, they're going to cross within 20 minutes, and you'll know very quickly if you're going to succeed. And if you don't succeed, there isn't a lot to lose by just stopping and then referring the patient to someone who has more experience with the full algorithm. Whereas if you are already proficient with the full algorithm, that's when I think the whole question of investment procedures comes into play. I don't know that I would be knuckling wires down into the distal bed and dilating it if I wasn't comfortable with the idea of doing stingray reentry or coming in retrograde. I think I would leave that for whoever you're going to refer the case to if that's something that you're not comfortable doing. I don't know, Manos, what you think about that.
No, I agree. I think, you know, things go smoothly, everything is fine. But then I mean, for me, the stopping has to do with, first of all, complications. You have a complication, you have an access complication, or you perforate it. Most of the time, you should stop because of safety reasons. Second big thing is radiation and contrast. If you're given 7-8 gray, you should stop because you're going to cause radiation, skin injury is not a good idea. Now, if you're doing okay and you have options, then the question in my mind is, are you comfortable with the next option and you have the equipment? If you understand retrograde, if you understand ADR, you have the equipment itself, then go for it. As long as your radiation is okay, no complications. But if you are not, I agree with Jay, that's when you stop and refer the patient to someone.
Perfect. And I believe there are very few documents in which they like very focally state when you should stop, because I remember the APEC algorithm, they specifically state that if you get more than 3.5 milliliter of contrast per creatinine of the patient, and if you go above 5 grays, then you should stop. But I can't recall many more documents in which they specifically say or state when you should stop a CTO intervention. I don't know if you recall any other like specific statement, guys.
Yeah, no, there is, again, these are the three, there is, the APEC is one, then also the EuroCTO has an algorithm published with their guideline that's about a year ago that was published. And now there's a Japanese algorithm as well that emphasizes the radiation. But the themes are the same: complications, contrast radiation, and lack of promising options. Or the fourth is the risk. If the option you can do, but the risk is, let's say, epicardial through a bypass patient, very high risk, maybe that's the one you're going to think is the benefit worth the risk and you should stop. But these are the four things to consider before stopping the procedure. And it's better to have a failed procedure, not a complication, than a successful, but with a bad complication. We had actually patients who died with successful CTO PCI with epicardial perforation, for example.
That's perfect. And the other very, very important topic is the ones that you have already said, is that you can't invest a procedure if you are not comfortable dealing with, for example, knuckle techniques or any other type of dissection technique which you are going besides your comfort line. So it's, I believe it's a very, very complex subject to address. And I also believe you should address the case to someone that can help you more in another attempt later on. Another question that's coming from the audience is, are all the IBUS equally useful, or do you prefer, for example, Volcano over Boston's because of the different tip in the IBUS, or is the same?
I think that there are some advantages to using the Volcano IBUS, particularly the short-term variety, because you can get very, very close to the cap. The Boston IBUS has about 10 to 12 millimeters of catheter that are distal to the imaging element, and there may not be room to park all of that in a lesion. So I think that there is an advantage to using the Volcano IBUS for these the cases that I showed you.
Manos,
I think I agree as well. You know, the reality of it is that most labs don't have both options. I think most labs have one or the other. So it's not an issue of choice. But if you have a choice, I think most people prefer the, you know, the Volcano, the solid state IBUS, because no need for preparation. You can put it very close and you have continuous imaging. The one downside of it is it's more bulky. So if you have like a very calcified, tight lesion proximally, you may have a hard time going through this. You may have to dilate that lesion to deliver the IBUS, just because it is so much more bulky than the rotational IBUS, which goes easier further down. But otherwise, you reach more distally, I agree, and it's easier to use.
Okay.
Getting to that point, there's another issue. So the Boston IBUS is low profile enough that you could fit a microcatheter, a low profile microcatheter and Boston IBUS in a 6 French guide. If you want to do IBUS guided puncture with a Volcano, you need a low profile microcatheter and at least a 7 French guide, if not an 8 French guide. So that's just a technical point.
Good observation. And another question that's quite repetitive, and I know that it's not the focus of this lecture, but many people are very curious. What's your percentage of Stingray usage for both of you?
That's a good question. You know, I think we have the advantage here that we'll be using this for a long time, and cost is less of an issue. So in our cases, I think in progress is about 25% or so of the cases are done with ADR, which is mainly Stingray. I think for me personally, it's in the 30% range. It doesn't always work. There is a steep learning curve, but there are some cases, if you don't have a retrograde option, that's the only thing you have. And if it doesn't work, then you're out of luck. So I think it's very, very useful. I know for when the budget is tight, it can be hard to use because of the cost associated. But if you can use it, it can be very useful.
Perfect.
I have to admit, I'm quite a bit lower. I'm quite a bit lower. I'm probably, I'm looking at my numbers right now. It's less than 10% Stingray reentry. I do a lot more parallel wiring, and then retrograde.
And I apologize for this mean question, but I would like to know what you think about AFR, antegrade fenestration and reentry.
Yeah, so I think for people who are not familiar with this, that's a technique that Mauro Carlino has pioneered with Lorenzo Cellini, in which if you don't have a Stingray, that's one way to get the antegrade reentry. So what you do is you put a balloon next to the area of dissection in the antegrade direction, and then a microcatheter next to it. And then, like the reverse cart for the retrograde, what you do, you inflate the balloon, that kind of creates some fenestrations. And when you deflate, you push a polymer jacket wire, Pilot 200 or something similar, and that may track a fenestration and go down the vessel. And actually, I know they're working on creating a specialized catheter to do this more automated way. But I think it's a good option. I have used it personally in a limited way, but if the distal vessel is good quality, it has a good chance to work. Like everything else, it does require that you have good experience with ADR. And the problem is, if you have Stingray, if you use this, you may take your Stingray option away because you increase the subintimal space, blowing up the balloon, and then Stingray may have less chance to work.
Jay, have you used the AFR technique?
I've never used it. I have a case that's coming up in 2 weeks that we are going to use it on, a prior Stingray failure.
Please, we would love to know about that case, how it turned out.
Yeah, we'll let you know.
And guys, we are running out of time, and there's a final question that everybody's doing, and they want to know it from you, that how would you start a CTO program? What's your advice for them?
Well, I mean, that's a really complicated question to try to answer in 5 minutes, but I think that the biggest thing is you have to have buy-in from your hospital and your administrators and your referring doctors to set up a program. If not all of those elements are in place, it's very, very difficult to generate the types of volumes to get the experience to really get proficient. And I think that it's the volume of cases that develops this proficiency. So you have to have all of these pieces in place. And I think that starting with the antegrade wire escalation as your dedicated strategy in the beginning and getting comfortable with that is a nice way to kind of segue into this full-fledged CTO program.
Perfect.
Yeah, I agree. I think the components there are 3 components. One is the operator. The second is the hospital and the system. The third is the patients. Now, for the operator, you have to want to do this. This is not something that you're forced to do. You have to really love to do complex cases, be a few years in, have some experience, and really want to learn this and do this properly. I think if you don't have that, then the rest is going to be a problem because you're going to get complications, you're going to have difficulties, you're going to be really motivated to do this. The second part, as Jay was saying, is critical to be in a place that lets you do this. For example, I'm doing my CTO and I have one lab. If the STEMI comes in, then I have to stop. There is a failed case. So you want labs that have at least 2 cath lab tables that they can do that. And then the third part is being a larger center. If your PCI volume is low, then it's going to be hard to create this. You have to be in a place that sees a lot of patients that have CTOs and need complex revascularization. So it's many different things, but having the passion is having the supportive system and a lot of patients is our key to make it successful in the long run.
Thank you very much. Unfortunately, we have run out of time, but I would not like to end this session without thanking you both, Jay Khatri, for your support, and Manos Brilakis for always trying to keep on teaching us these complex techniques outside from your book and all your videos in YouTube. We are very, very glad that you have joined us in these sessions, and thank you very much for everything. I will switch to Spanish so I can say goodbye to everyone. And thank you very much, guys, for taking part in this session. Thanks a lot.
Thank you, Marco.
En nombre de SOCIME y esta asociación tan provechosa que ha habido con SCAI, les queremos dar las gracias por acompañarnos en esta sesión en donde tuvimos a un par de invitados de lujo, el doctor Jaikirshan Khatri y el doctor Brilakis, que yo creo que todos los conocemos en el mundo de los que hacemos intervencionismo, inclusiones crónicas y el intervencionismo complejo. A nombre del presidente de SOCIME, el doctor Yigal Piña Reina, queremos darles las gracias por habernos acompañado y los esperamos en el próximo seminario de SOCIME. Muchas gracias y buenas tardes. Hasta luego. Thank you very much, guys.
Bye.
Thank you.
Bye.
Thank you so much. Have a wonderful night. That was wonderful.
Thank you, Dr. Brilakis. Thank you, Jay. Nice to meet you.
Thank you so much. Sorry for the sound issues. Glad it worked out in the end.
It turned out fine. Thank you very much.
Wonderful. Thank you.
Bye.
Lots of fun. Take care, guys.
Have a good night.
Thank
Bye-bye.
you.
Dr.
Be
Cautery,
safe.
thanks, Dr. Brilakis.
Thank you, Eric.